Imagine an alarm system so hypersensitive that, like, a single leaf falling on your driveway triggers a total permanent lockdown of your entire house.
Right, yeah.
The doors bolt, the windows shutter, and you're just trapped inside, all because of a leaf. Today, we are looking at a deeply misunderstood chain reaction in the human body that does exactly this.
It really does.
Welcome to the deep dive. Our mission today is to explore how a tiny chemical leak in a distressed bladder, like what happens in overactive bladder syndrome or interstitial cystitis, can actually trigger a state of constant, exhausting tension in the pelvic floor muscles.
Yeah, the connection is wild.
And we're going to trace how that permanent muscular lockdown completely hijacks your body's sexual arousal system, which ultimately leads to painful intercourse or what is clinically called dyspareunia.
It is an incredibly complex cascade of events, When you look at the medical literature, the clinical guidelines like from NICE, and then the highly specialized research on pelvic floor physiology we're pulling from today, you realize how dangerously interconnected everything in the pelvis actually is.
Okay, let's unpack this, because I feel like for a long time, the public understanding of the pelvic floor has just been, well, a structural hammock.
Right, like a literal sling.
Yeah, just this physical sling of muscle holding up the bladder and the bowel and the uterus. But the research paints a completely different picture, doesn't it? This is a highly emotional, highly reactive sensory organ.
What's fascinating here is that the organs in your pelvis do not operate in isolation. I mean, they share a literal neural fuse box.
A fuse box.
Yeah, the nerves supplying the bladder, the bowel, the reproductive organs, they all overlap and communicate, meaning a problem in one organ can very easily become a problem in another entirely different organ.
So, like, the bladder is chemically burning and that fire just spreads. Let's start right at the origin point of that irritation. What is actually going wrong inside the bladder?
Well, the foundational issue usually starts with conditions like interstitial cystitis, often abbreviated as IC or painful bladder syndrome. And we also see similar mechanisms in overactive bladder or OAB. IC is a condition that presents as pelvic pain, pressure, or extreme discomfort related to the bladder, paired with a persistent, frantic urge to pee, but notably without any actual infection present.
Right, and looking at the numbers in our sources, this predominantly affects women. I mean, the female-to-male ratio of people diagnosed with IC is roughly 10 to 1.
It's a huge disparity.
And it is also frequently misdiagnosed as endometriosis or recurrent UTIs because the symptoms mimic them so closely, right?
Exactly. To understand that sort of phantom symptom profile, we really have to look at the microscopic lining inside the bladder itself.
Okay, what's going on in there?
In a healthy bladder, there is a protective barrier called the JAG layer. It acts like a waterproof coating, basically preventing the toxic waste products in your urine from seeping into the delicate tissues of the bladder wall. But in IC, that lining breaks down.
So the waterproof coating springs a leak. And specifically, the research points to potassium leaking through into the tissue, right?
Yeah. Yes, exactly. Potassium leaks through that compromised bladder lining, and it comes into direct contact with the underlying nerves and muscle tissue.
Ouch.
Yeah, that causes intense irritation. That nerve activation triggers local mast cells to release histamine and other inflammatory agents.
Right, I'm struggling with this a bit. Because inflammation is usually the body's way of healing, right? Like if I cut my finger, my body sends blood and white blood cells, which is inflammation, to fix the problem.
Right.
So why does this specific inflammation in the bladder just create an endless loop of damage instead of, actually fixing it?
Because the irritant never leaves. I mean, in your cut finger example, the immune system clears out the bacteria, it scabs over, and the inflammation recedes.
Right.
But in the bladder, urine is constantly being produced, so the potassium is constantly hitting those exposed nerves.
Oh, wow.
Yeah, so the histamine release creates tissue swelling and damage, which further breaks down that protective gag layer, which then allows even more potassium to leak through. It is just a vicious, self-sustaining cycle of localized inflammation.
Okay, that makes sense of the physical damage. But how does a localized microscopic chemical burn translate into that frantic, overwhelming urge to find a bathroom immediately?
Yeah.
Because, sometimes people feel like they're going to burst when there's barely a tablespoon of fluid in there.
It comes down to how the bladder communicates with the brain. Normally, your bladder acts as this really sophisticated, graded sensory organ.
All right.
When it fills up to about 40% capacity, stretch receptors send a polite, mild signal to your brain. And you get a stronger, more urgent signal when it gets closer to, say, 90% full.
So it's like a volume dial that turns up slowly.
Exactly. But in conditions like overactive bladder and IC, that volume dial is completely destroyed by a specific type of nerve called a C fiber.
The C fiber.
Yeah, C fibers are usually completely silent. They're essentially emergency nerves that only respond to noxious, painful, or tissue-damaging stimuli.
Ah.
But because of that constant potassium irritation and the histamine storm we just talked about, these previously silent C fibers wake up.
So the emergency alarm gets tripped. It's like the faulty car alarm going off just because a leaf touched the windshield.
That's a perfect way to put it. They become highly active during normal low-volume bladder filling.
Oh.
Right. So instead of the brain getting a polite message saying, hey, we're at 40%, these C fibers are screaming, we are completely full and in imminent danger when there's barely any fluid in there at all.
Mm.
The entire local nervous system just becomes violently hypersensitive.
Okay, so the bladder is essentially experiencing a chemical fire, and its emergency alarms are screaming at the brain. But, and this is what I want to get to, the bladder is just a muscular sac holding fluid.
Right.
Why does a localized chemical burn inside the bladder cause the structural muscles completely outside of it, like the pelvic floor, to lock up?
It comes back to that neural fuse box we mentioned earlier. The medical term for this phenomenon is neural convergence, or sometimes they call it crosstalk.
Crosstalk.
Yeah. The afferent nerves, those are the sensory nerves carrying messages up to the brain. From the lower urinary tract, the bowel, and the gynecologic organs, they all travel back and meet in the exact same control areas in the lower spinal cord, specifically the lumbosacral region.
Here's where it gets really interesting. Because these nerves all converge and plug into the same spot on the spinal cord, the central nervous system gets confused, right?
Exactly.
It is receiving these frantic, screaming pain signals from the bladder's C fibers. But the brain can't perfectly pinpoint the origin of the distress. It just registers like massive danger in the pelvis.
And that confusion triggers a specific neuropathic reflex called visceromuscular hyperalgesia.
That's a mouthful.
It is. But basically, the brain perceives a catastrophic threat in the pelvic basin, and its immediate evolutionary response is to command the surrounding pelvic floor muscles to tense up. It's a guarding reflex.
A guarding reflex.
Yes. The muscles are contracting to physically armor the area against this perceived severe injury.
But the threat isn't mechanical, like nobody is punching them in the stomach. The threat is a chemical irritation inside an organ, so the muscles are constantly guarding against a threat they can't actually fight off.
Precisely. And if we connect this to the bigger picture, you can see how devastating this becomes over months or years. This isn't a reflex that just happens once and resets.
Right, because the bladder is constantly irritated.
Right. So the muscles receive a constant neurological command to guard. Over time, the central nervous system actually gets trained into a permanent state of heightened vigilance.
Wow. So the spinal cord and the brain essentially become too efficient at generating pain responses.
That is called central sensitization. The nervous system is upregulated, pain becomes amplified, and it begins to spread across the entire pelvic region, far beyond the original bladder trigger. The neural pathways effectively learn to be in pain, and they refuse to unlearn it.
So now we have a situation where the pelvic floor muscles are receiving a relentless 247 neurological command to clench. What actually happens to the physical biology of a muscle when it is forced into a defensive spasm that never ends?
Well, it develops into an overactive pelvic floor, or OAPF. You'll also hear it called pelvic floor hypertonicity.
Okay.
And it is crucial to understand that this is not just muscle tightness, like, having tight hamstrings after a run. It is a pathological state where the muscles absolutely refuse to relax. And they often actively contract when they are functionally supposed to be relaxing, like during urination or having a bowel movement.
Man, the biological toll it takes on the muscle tissue is just brutal. Because when a muscle is constantly tense, it physically squeezes its own capillaries shut. It restricts its own blood flow, which is a condition called ischemia, right?
Exactly. And without adequate blood flow, the muscle cells are starved of oxygen.
And when a muscle operates without enough oxygen, it switches its metabolic process and builds up lactic acid. It's the same thing that happens when you sprint as hard as you can, except these muscles are sprinting while you are just sitting at your desk or trying to sleep.
It's exhausting just to think about.
And the literature also notes this ischemic state causes the release of inflammatory cytokines, specifically one called bradykinin, which just creates a localized feedback loop of even more inflammation and pain in the muscle itself.
Yeah, it creates an environment of total cellular exhaustion and toxicity.
It makes me think of carrying a heavy grocery bag.
Oh, yeah.
Like, imagine holding a heavy bag of groceries with your arm bent at a right angle.
Yeah.
For the first minute, your bicep feels strong. But if you hold it there for 3 days straight,
Right.
that muscle isn't strong anymore. It's completely exhausted, it's full of painful knots, and ironically, it is functionally weak because you have zero range of motion left. You can't bend it or straighten it.
That is exactly what is happening in the pelvic floor. The decrease in blood flow, the shortened muscle fibers, the lactic acid bath, it leads directly to the development of myofascial trigger points.
Trigger points.
Yeah, these are taut, highly sensitive bands of muscle fibers that feel like hard, painful nodules.
And the overlap between the bladder issue and this muscle exhaustion is staggering. I mean, the research states that an enormous 75% of patients with IC or painful bladder syndrome also have pelvic floor dysfunction.
Which highlights a massive gap in how this is often treated. If a doctor is only prescribing medication for the bladder, they are missing a huge piece of the pathology.
Because the muscles have become their own problem.
Exactly. They've become an independent source of severe dysfunction.
Which brings us to the core mystery we set out to solve today. How does this collision of a screaming bladder and an exhausted, locked-up pelvic floor interact to cause baseline arousal-induced dyspareunia? How does this destroy someone's ability to have painless sex?
Well, to understand why it hurts so much, we first have to map out the physiology of normal female sexual arousal. It relies on a very precise, sequential hydraulic and neurological process.
Okay, break that down for us.
When there's genital stimulation, afferent sensory nerves send signals up to the somatic sensory cortex in the brain.
So the brain recognizes the stimulation, and it fundamentally changes the nervous system's output. It turns down the sympathetic input like the fight-or-flight stress response, and it cranks up the parasympathetic activity, the rest and digest response.
Yes, that parasympathetic shift is the biological key to arousal. It causes the release of a neurotransmitter called nitric oxide in the pelvic region.
Okay.
And nitric oxide is a powerful vasodilator. It causes the smooth muscle in the blood vessels to relax and open up wide, leading to a massive, rapid increase in blood flow to the clitoris, the labia, and the vagina. This is clinical vasocongestion.
And this is where the mechanics become incredibly important. For that vasocongestion to happen, for the blood to actually pool and swell on those tissues, the pelvic floor muscles surrounding those blood vessels must be completely relaxed.
Absolutely. If the muscles are relaxed, the blood vessels expand and blood flows in freely. That heavy vasocongestion increases what is called oncotic pressure within the vaginal submucosa.
Oncotic pressure.
Right. And that pressure physically pushes a fluid transitate through specialized cellular channels in the vaginal wall called aquaporins.
Whoa, hold on. Let's translate that. Oncotic pressure and fluid transitate. Are you essentially saying that the rush of blood creates so much physical hydraulic pressure behind the walls of the vagina that it literally squeezes fluid out through the cell walls, like water being pushed out of a sponge, to create natural lubrication?
That is precisely how it works. The blood volume creates hydraulic pressure, and that pressure filters fluid directly through the mucosal walls to lubricate the vestibular and vaginal surfaces.
Oh, wow. I get it now. It's entirely a plumbing issue. The muscles are clenching so hard they are literally pinching the hoses shut.
Yes. If a patient has an overactive pelvic floor because their muscles are guarding against bladder pain, their normal arousal sequence hits a literal brick wall.
Right.
The hypertonic muscle tension physically compresses the blood vessels. Vasocongestion simply cannot happen if the blood cannot get past the locked muscles.
So if the blood can't get in, the hydraulic pressure can't build. And if there is no hydraulic pressure, the lubrication system physically cannot turn on. The fluid never gets pushed through the walls.
Exactly. The physiological result is a profound lack of lubrication, paired with incredibly tight, rigid tissues that are already suffering from a lack of oxygen.
Which leads directly to dyspareunia. I mean, without that vasocongestion and without that hydraulic lubrication, attempted intercourse creates severe damaging friction.
It does.
You are dealing with direct mechanical trauma to the vestibular mucosa. That's the delicate tissue at the entrance to the vagina. It is described in the clinical literature as a sharp, burning, tearing, or stinging pain.
And the mechanical blockage of blood flow isn't the only roadblock. We also have to look at the mechanics of orgasm itself.
Okay, yeah.
In a healthy system, the physical sensation of orgasm is induced by a series of involuntary, rhythmic pelvic floor contractions. The muscles contract and release at an interval of roughly every 0.8 seconds.
So it's a natural pulsing. Contraction, complete release, contraction, complete release.
But consider the state of our hypertonic pelvic floor. It is already exhausted, oxygen-deprived, and full of painful trigger points from guarding the bladder 24/7.
Right, it's totally locked up.
Right. So when the brain sends the rapid-fire signal to perform those 0.8-second rhythmic contractions, the muscle simply cannot execute them smoothly.
Instead of a rhythmic release, those natural contractions turn into painful clonic spasms.
Exactly.
The muscle is just seizing up. The orgasm itself becomes a source of intense physical cramping and pain,
Right.
rather than pleasure, because the muscle is violently misfiring.
It's a devastating cascade. A chemical leak in the bladder creates a false alarm, which locks the muscles, which pinches the blood vessels, which shuts down the hydraulic lubrication system, which turns sexual function into a source of mechanical trauma.
But the physical mechanics are really only half the story. Because once sex becomes mechanically painful, a whole new loop begins, right? The psychological loop. And this is where the condition truly entrenches itself.
That's right. Repeated episodes of dyspareunia inevitably initiate a deeply conditioned fear of pain. If an activity caused tearing, burning pain the last 3 times, your brain is absolutely going to anticipate severe pain the 4th time.
Yeah, of course.
And this raises an important question. How does the brain's anticipation of pain physically alter the environment of the pelvis?
Well, the biological wiring here is fascinating. The pelvic floor musculature is heavily influenced by the limbic system. That's the emotional processing center of the brain, the part that handles fear, anxiety, and survival instincts.
Right.
And from an evolutionary standpoint, the pelvic floor is highly reactive to emotional stimuli. Think about a dog tucking its tail between its legs when it's scared. That's a pelvic floor contraction driven by fear.
Humans have that exact same deeply wired reflex. When a person anticipates pain during intimacy, the limbic system triggers an involuntary, unconscious, defensive clenching of the pelvic floor. The emotional brain is just trying to protect the body from the pain it remembers.
But that defensive, fear-based clenching makes the baseline hypertonicity even worse, which restricts the blood flow even more, which prevents lubrication even more, which makes the mechanical friction worse, which makes the pain more severe, which makes the fear even stronger the next time.
It is a brutal, self-fulfilling fear-tension cycle.
The anxiety physically creates the conditions for the pain, which then just validates the anxiety.
This is why the clinical guidelines, like those from NICE in the UK, stress that treating this condition requires a biopsychosocial approach. You cannot just give a patient a pill to coat their bladder and expect their sexual function to magically repair itself.
Right.
You have to treat the localized organ, the exhausted muscles, and the nervous system's conditioned emotional responses all at the exact same time.
So let's explore those treatments, specifically the non-surgical interventions highlighted in the research. Because if the muscles are the literal physical roadblock to arousal, we have to fix the muscles.
Pelvic floor physical therapy is paramount here, but it is vital to specify exactly what kind of physical therapy. We are absolutely not talking about Kegel exercises.
Oh, I'm so glad you brought that up, because Kegels are universally pushed as the default solution for any pelvic problem.
They are, and it's a huge problem.
Yeah, because Kegels are for strengthening a weak, lax pelvic floor by actively tightening it. If your pelvic floor is already trapped in a hypertonic, exhausted spasm, doing Kegels is like telling someone with a severely cramped, seizing calf muscle to stand on their tiptoes and flex as hard as they can.
Exactly.
It's going to make the ischemia and the pain so much worse.
It is the exact opposite of what the body needs. For an overactive pelvic floor, the physical therapy focuses on what is called down training. It is an intricate process of teaching the nervous system and the muscles how to finally let go and relax.
And the sources outline specific manual therapy techniques to achieve this, particularly myofascial release, to treat those painful trigger points. There's a highly specific technique mentioned called Thiel massage.
Yeah, Thiel massage is an internal digital massage, usually performed through the vagina or rectum by a specialized pelvic floor physical therapist.
Okay.
They use very specific rhythmic sweeping motions to manually stretch and release the tightness in deep pelvic muscles like the levator ani. It physically breaks up those hard trigger points, restores the blood flow that was restricted by ischemia, and helps reset the local stretch receptors in the muscle fibers.
So you are manually overriding the muscle spasm, forcing blood back into the tissue so it can breathe again.
Right.
But because we know the limbic system and the fear of pain are constantly threatening to lock those muscles right back up, physical therapy often isn't enough on its own, is it? I mean, you can fix the muscle on Tuesday, and an anxiety spike on Wednesday can lock it back down.
Which is why the medical literature strongly recommends pairing physical therapy with cognitive behavioral therapy, or CBT, as well as specialized sex therapy. CBT helps address the psychosexual distress. It gives patients actionable tools to manage the anxiety and fear of pain. By managing the fear, you directly reduce the limbic system's subconscious command to the pelvic floor to clench.
You have to rewire the brain's alarm system at the exact same time you are massaging the physical knot out of the muscle. You're treating the hardware and the software simultaneously.
It requires immense patience, but the research shows that by combining dietary and medical treatments for the local bladder inflammation, manually downtraining the pelvic floor musculature, and addressing the psychological fear tension loop, real, lasting headway can be made in restoring sexual function and dramatically reducing pain.
It is incredibly validating to see the mechanics of this laid out so clearly in the medical literature. So as we wrap up this deep dive, I want to speak directly to you listening right now. If you or a partner or friend are dealing with mysterious pelvic pain, relentless bladder urges, or sharp pain during sex, please know this. It is not all in your head.
It is a deeply documented, highly complex neurological and muscular chain reaction. The origin might be invisible to the naked eye, but the physiological blockade of blood flow and muscle function is very, very real.
It starts with microscopic chemical leaks. It travels up the spinal cord to confuse the brain. It alters hydraulic blood flow, and it physically locks down muscles. But precisely because it's a physical mechanical chain reaction, it can be unraveled with the right multidisciplinary approach.
It just requires healthcare providers to look at the interconnected system rather than isolating the parts.
And that actually brings me to a final thought I want to leave you with today. Our medical system, and, well, our society in general, often treats the human body like a machine made of completely isolated parts.
Yeah, that's true.
We go to a plumber for the bladder, we go to a mechanic for the muscles, we go to a programmer for the brain. But when we look at how intimately our emotional state, like the fear of pain, or even just our daily mundane anxiety, can instantly, physically lock up the muscles deep inside our pelvis, we really have to ask a much bigger question about how we live.
It completely changes how we view the origin of physical tension.
Right. To what extent are our physical bodies actually holding on to the emotional weight of our unexpressed stress? If a feeling of anxiety can literally cut off blood flow to a muscle and create a permanent, painful knot, is it possible that our bodies are acting as a secret, silent diary of our daily anxieties? Are we unknowingly writing our emotional history into our very muscle fibers every time we swallow or stress?
It's a profound and necessary way to look at chronic pain, and it reminds us that healing the body often requires making peace with the mind.
Thank you for joining us on this deep dive into the source material. We'll see you next time.